Non-laminotomy bilateral decompression. A novel approach in biportal endoscopic spine surgery for spinal stenosis. Say Gill Hospital and Yonsei University College of Medicine. Disclosure. We authors have no conflicts of interest to disclose. As minimally invasive surgery has several advantages. Biportal endoscopic spine surgery is gaining popularity. Most of all, it is patient-friendly. We authors are going to present the new biportal endoscopic spine surgery technique for lumbar spinal stenosis patients. First, let's understand the definition of spinal stenosis and then consider how to treat it. Spinal stenosis refers to any narrowing of the spinal canal, nerve root canal, or intervertebral foramen resulting in highly variable sign and symptoms. Or is a nebulous diagnosis indicating a narrowing of the lumbar spinal canal resulting in compression of the neural element. The definition of spinal stenosis includes the concept of neural element compression. We are well aware that various compressive neuropathies are treated with decompression. So, what about the spine? We know that it is not fundamentally different. Spinal stenosis requires optimal decompression. Certainly, past surgeons also knew that spinal stenosis requires decompression. However, because the spinal cord is protected by bone, they performed wide laminectomies, similar to how a craniectomy is performed in the brain. The latter half of the 20th century, a wide range of surgical techniques has been developed for decompression of the spinal cord, leading to terminology confusion. However, these confusion reached consensus among the pioneers of that time and were based on similarities in nomenclature with cranial surgery. Any surgical technique involved some degree of bone resection. In particular, wide laminectomy was later associated with lower success rates due to the development of segmental instability from bone loss. Consequently, there was a surge in fusion surgery in the latter part of the 20th century. While fusion might be considered as an initial treatment for spinal stenosis, it does not align with general treatment principles or the definition of spinal stenosis. In no other part of the body would fusion be used as an initial treatment for compressive neuropathy. Moreover, numerous studies have shown that fusion surgery with instrumentation is riskier compared to decompression. It has been proven in highly reputable journals such as NEJM and JAMA that even in patients with degenerative spondylolisthesis, fusion is not superior and incurs higher societal costs and risks. Therefore, fusion cannot be considered an initial treatment for spinal stenosis. So, what should the spine surgeons do? Surgeons would prefer to avoid fusion. In other words, they do not want to create segmental instability in their patients. The spine specialists are comparing various surgical techniques to find the optimal approach. Clinically, it is evident that minimally invasive techniques have a lesser impact on the occurrence of segmental instability. Simply put, biomechanical studies commonly conclude that less bone resection results in less instability. In 2021, Spina directly stated in their paper that increased bone resection results in increased pars stress. And as bone removal increased from intact to 75%, the facet joint force decreased. That means weakening of the facet joint function and can be a cause of spondylolisthesis. So, it seems that the less bone is resected, the more stability is maintained. We introduce a novel decompression technique called non-laminotomy bilateral decompression, NLBD. This new approach diverges in that it performs decompression solely through the interlaminar space, removing the ligamentum flavum and osteophytes without conducting osteotomy. Gill Hospital used to perform ULBD. During clinical practice of corresponding author Dae-Young Lee, he felt that patients with less bone resection had better outcomes. So, he had been gradually reducing the amount of lamina resection. Resect less, less and less, and even less. At some point, he came to the realization that NLBD might be feasible. He integrated his arthroscopic techniques into BES. After numerous attempts and practice, NLBD can be achieved safely and reproducibly. After then, Gill Hospital has been performing non-laminotomy bilateral decompression, NLBD, since December 2023. From January to August 2024, the hospital conducted biportal endoscopic spine surgery on a total of 458 patients, with approximately 9.45% of those patients not being suitable for NLBD. The goal of this video is to demonstrate that non-laminotomy bilateral decompression is possible. The human lumbar spine has a naturally usable bony window at each level known as the interlaminar space, which makes NLBD feasible in most patients. To perform NLBD, the surgeon must be skilled in using a curette that can apply three-dimensional rotational force. Additionally, since the surgeon needs to perform portal switching during the procedure, they should be able to use both hands freely. Any surgery can be performed if working is possible under adequate visualization. As mentioned earlier, if the surgeon can freely use arthroscopic equipment in both hands and is skilled with the curette, performing NLBD becomes entirely feasible. About the viewing, an arthroscope with a 120-degree field of view allows sufficient visibility by navigating the interlaminar space. As shown in the figure, scope is different from conventional open surgery because it positions the surgeon's eyes closer to the spine. Moreover, the structures visible from the proximal portal and distal portal differ. The ipsilateral SAP is often more visible from the distal portal, so it is especially important to switch hands during this time. And about the working capability, by using curettes of various sizes, adequate working capability was achieved. As shown in the introduction video, unlike the linear movement of the punch, the curette allows for the transmission of rotational force. Additionally, the curette's action, which operates primarily in an upward direction, reduces the risk of dura injury. Furthermore, as seen in the figure comparison, the use of the curette during recess decompression results in less nerve compression compared to the punch. At times, the surgeon may need to switch the portal when the tip of the curette has difficulty crossing to the contralateral side due to the prominent lower laminar center. This is also why it is important to be proficient in using the curette with both hands. In conclusion, after various attempts, positioning the arthroscope close to the interlaminar foramen, securing visibility, and three-dimensional rotational curette works made it possible to achieve both viewing and working through the interspinous foramen. That is, NLBD was possible. We will now discuss the 9 bony checkpoint principle that need to be assessed for complete bilateral decompression. The 9 bony checkpoint is attachment site of ligamentum flavum. As it requires a three-dimensional understanding, we authors have created a three-dimensional schematic diagram, which is also a key emphasis of this video. Once the ligamentum flavum is detached from all 9 attachment points, it becomes completely free as there are no further insertions. There is no specific order for checking the 9 points. The surgeon needs to flexibly verify all 9 bony checkpoints according to the situation. However, for the starting point, we recommend point 1, the ipsilateral lower laminar upper border, as it is a constant bony landmark that can be easily identified under C-arm guidance. Thoroughly expose all 9 attachment sites of the ligamentum flavum. It can be easily and completely removed with osteophytes. Case overview. A 79-year-old female patient presented with neurogenic claudication. Her neurogenic claudication was so severe that he struggled to walk a single block of road. She felt painful discomfort in both buttocks immediately upon standing. MRI revealed moderate to severe spinal stenosis at 2 levels. So, we decided to perform NLBD. 2 portals were created at the locations indicated by the C-arm, positioned slightly more towards the midline compared to conventional BES. The surgeon felt the hard bone during ablation to confirm orientation, then immediately palpated point 1, the ipsilateral lower laminar upper border. The surgeon is aware of the bony depth and knows that removing structures shallower than the inferior lamina is not risky at all. The surgeon is approaching the interlaminar foramen using the curette and arthroscope device. It is important to thoroughly dissect and remove the soft tissue between the lower lamina and IAP. Through this process, the superficial ligamentum flavum attached to the IAP can be removed first, allowing for the sequential differentiation and removal of the deep ligamentum flavum that attaches to the SAP. Using the pointed tip and rounded underside of the curette appropriately, the surgeon penetrated the deep ligamentum flavum, exposing the dura. Even after the dura is exposed, it is advantageous to remove the superficial ligamentum flavum first, according to the depth. The surgeon is currently removing the ligamentum flavum attached to the more superficial IAP before addressing ligamentum flavum attached to the SAP. After determining that the superficial ligamentum flavum attached to the distal IAP has been sufficiently removed, the surgeon meticulously removes the attachment of the ligamentum flavum at the junction between the lower lamina and the SAP, exposing the bone. Next, the surgeon will safely guide the curette, using its rounded underside, from the inferior lamina down toward the SAP. A powerful rotational movement of the curette was performed, and a significant amount of ligamentum flavum was removed, and the central ligamentum flavum cleft was revealed. The curette can now be safely guided through the cleft to reach the undersurface of the ipsilateral superior lamina. The surgeon concluded that the ligamentum flavum was not pulled and removed by the pituitary forceps because it was still strongly attached to the bony point and had not been undermined yet. To better visualize the obscured SAP, the surgeon performed a portal switching. After thoroughly undermining the SAP undersurface, the surgeon repositioned the portal to its original location. Using the curette again, a rotational movement followed by an upward lifting force can now be applied, allowing a significant amount of ligamentum flavum, which is now free of additional attachments, to be removed. Having determined that the ipsilateral ligamentum flavum has been sufficiently removed, the surgeon is now proceeding with the contralateral side. The basic 9 bony checkpoint principles remain the same as those applied during the ipsilateral surgery. With the ipsilateral ligamentum flavum already removed, the surgeon has a clear understanding of the dura's depth, making the approach easier. However, it is still good practice to first remove the superficial ligamentum flavum to improve visualization before proceeding to remove the deeper ligamentum flavum. Sequentially, the superficial ligamentum flavum of the distal IAP was removed first, followed by the ligamentum flavum attached to the SAP. The ligamentum flavum of the proximal IAP was removed. After removing the ligamentum flavum attached to the undersurface of the superior lamina and clearing away the debris, the bony checkpoints and shoulder can be identified. While the bony checkpoints and shoulder on the ipsilateral side can be better observed using the distal portal as the viewing portal, they can also be adequately inferred from the proximal portal. The surgery at the first level has been completed, and for the second level, a brief explanation will be provided using figures related to the 9 bony checkpoints, without detailed narration. We confirm that complete decompression has been achieved by comparing the MRI images before and after the surgery. And no bony changes can be observed not only on X-ray but also on CT. Case overview. A 60-year-old female patient presented with buttock pain. She presented with neurogenic claudication, which occurred after walking for about 5 minutes, and painful discomfort in the buttock arose immediately upon standing. She also complained of decreased sensation in both feet, and an X-ray revealed spondylolisthesis. MRI revealed moderate to severe spinal stenosis at 2 levels. So, we decided to perform Nlbd. This surgery is a typical Nlbd, with the only notable aspect being that the right-handed surgeon operated from the patient's right side. The explanation will primarily focus on the figures, with only some brief narration provided. We confirm that complete decompression has been achieved by comparing the MRI images before and after the surgery. And no bony changes can be observed not only on X-ray but also on CT. It seems that our technique have advantages of, first, since there is no bone resection, there will likely be less instability, reduced pars stress, and decreased osteoclast activation, resulting in less pain and instability. Second, with less bone bleeding, the incidence of hematoma is expected to be lower. While epidural bleeding is still the most problematic, you will not have to struggle with issues like bone wax techniques. Third, NLBD surely does not use burrs at all. As is well known, the use of burrs is one of the most common causes of incidental durotomy. In NLBD, there is no strangulation of the spinal cord or nerve fibers, and it is expected that the likelihood of incidental durotomy or fiber transection is significantly lower. This technique has limitations. First, the NLBD cannot be performed in cases where the interlaminar space is significantly narrowed. Based on the author's experience, if the interlaminar space measures less than 3 mm on CT, it is difficult to decompress the spinal canal without partial laminotomy. Or the shallow lateral recesses of the trefoil shape of the lumbar spinal canal can be problematic either. In such cases, some lamina cortex may need to be removed during the approach to create adequate viewing and working space. Second, if both hands are not well practiced with the curette and arthroscope, limitations may arise during surgery. Additionally, there is a lack of clinical evidence. Future research comparing the approach of the existing ULBD method with the technique described in this technical note is expected to be an important aspect of advancing minimally invasive spine surgery. Despite these limitations, the NLBD method could represent an alternative surgical approach that allows for decompression of spinal stenosis without bone resection. This video was meticulously created to demonstrate that NLBD can be reproducibly performed. We hope that our detailed surgical video will help spine surgeons consider trying NLBD when performing decompression for future lumbar spinal stenosis patients. Thank you for watching.